Okay, good morning, everyone. We're going to get started with rounds. Welcome to Wednesday morning general cardiology rounds. It's my pleasure this morning to have a guest from TOH. Dr. Rosenberg is going to be presenting today. She received her medical degree in 2007 from the University of Ottawa, and then went on to do her medical training internal medicine and critical care training. She's a fellow of the Royal College with a specialty in both internal medicine and critical care. And she's also completed a master's in health administration. In 2019, she became part of the examination board for the Royal College in critical care, and she's junior faculty member for the clinical practice committee and is the civic site representative for the residency program. She's the incoming site chief for the general campus ICU and current lead for the quality and patient safety department of critical care. So we're very happy to have her today and give us an update on critical care for the cardiologist. And as we all know, we have a fair number of these patients in our institution. So we look forward to having your presentation today.
Hi, everyone. Thanks so much for having me. I was asked to do this talk and was said, tell us about critical care stuff for the cardiologist. And I thought, oh my gosh, what am I going to talk to these people about? Trying to make it useful, thinking about, I don't think sepsis and COVID ventilation is really the bread and butter of cardiology, so I did not choose to do that. What I'm going to talk more about is a lot about what happens to our ICU patients afterwards. So long-term outcomes of ICU, and then what we can do while these patients are in the ICU to try to mitigate those outcomes afterwards. So we're going to review something called the A2F bundle and the different components within it. We'll talk about long-term outcomes associated with both delirium and critical illness in general. And then we'll try to understand and recognize something called post-intensive care syndrome that sort of the topic has been around for probably about 8 or 10 years, but really coming more into being discussed a lot more in recent years. What we know about critical care in the 21st century is that we've made lots of advances, right? Not nearly as many people are dying in the ICU anymore. Our mortality rates have decreased significantly. But unfortunately, what we've seen is that people are surviving, but they're not recovering. Okay, so these people are not going back to being the functional people who they were before. They're left with many long-term outcomes. And so what we really are trying to look at more now, and many ICU studies are really focused on not having mortality as the primary outcome anymore, but having functional status as the primary outcome, or at least one of the outcomes afterwards, looking at quality of life of these patients, not only for them, but their families as well. And so how do we go about doing this? How do we try to improve recovery in our ICU patients? And this is where something called the ABCDEF bundle, or A2F bundle to make it shorter, was laughed because I feel like over the years, so that it started off as the ABC bundle, and then it became the ABCD bundle, and then it became ABCDE, and then they added F, and I'm just waiting for like G and other letters to come into it. But currently we are only at the 6 letters. But it is really nice bundle of care that looks at things that we can do while patients are in the ICU to try to mitigate, not only mitigate the long-term outcomes, but also improve outcomes overall. So the aspects of this bundle are, the A is for assessing, managing, and preventing pain. The B is for both spontaneous awakening trials and spontaneous breathing trials, which are combined together. C is for choice of analgesia and sedation. So what drugs are we giving these patients in the ICU? Then we can look at D for delirium, which is we want to assess, prevent, and manage delirium. Early mobility and exercise is our E. And then F stands for family engagement and empowerment. When we look at studies that have implemented, of places that have implemented the entire A2F bundle, the outcomes are pretty impressive. So within 7-day mortality has decreased by 68% in some of these studies. Delirium and coma is reduced by anywhere from 25 to 50%. Physical restraint use is reduced by more than 60%. And I don't know what the state is in your CICU, but physical restraint use is rampant in our ICUs. And I think it is unfortunately sometimes used inappropriately and actually makes patients worse. So anything we can do to try to limit physical restraints is good. We can reduce ICU admissions by 50%. And then decrease our discharges to a facility other than home by 40%. So that's reducing patients going to retirement homes, nursing homes, long-term care facilities, chronic care facilities like St. Vincent's by more than 40%. So it's, all of those are like very impressive outcomes, really, by implementing this entire bundle of care. And so we're going to go through and take each individual component and look at them. So the first one is pain. We know that patients in the ICU experience pain. And unfortunately, more than 75% of patients remember that pain. And it's the most not important, but the most prevalent memory that they have of their time in the ICU is of being in pain in the ICU and often not being able to actually communicate that pain. Patients remember this for even up to 6 months afterwards. We know that severe pain, we obviously don't want to have our patients in pain, but it also actually affects them and their status. So we get increased catecholamines from pain, more catabolism. Our patients are already so catabolic in the ICU and lose so much muscle and weight while they're there. We get a reduction in NK cell activity and therefore immunosuppression. And then we can think about the ramifications after our ICU stay. So patients often go on to develop chronic pain after the ICU. They can develop post-traumatic stress disorder, which we'll talk more about later. And then one thing that's becoming more and more recognized now with the opioid epidemic is that patients are developing opioid use disorders from being on opioids in the ICU and becoming dependent on them. And so how do we best manage pain? Well, we know that opioids, unfortunately, are still the mainstay of therapy. However, they're not without risks. Sedation is one of them. Now, sometimes, we'll talk about this a little bit later, we take advantage of the sedating effect of opioids, but delirium is definitely a risk, respiratory depression, ileus, immunosuppression, and they actually may lengthen our ICU length of stay and worsen our ICU outcomes by using opioids. That being said, we know, as we said, that we don't want patients to have pain. So what can we do to try to prevent that pain or reduce the opioids? We can try to use adjuvants. So things that are recommended, acetaminophen, ketamine, which certainly in our ICU became a lot more prevalent in COVID when we had so many drug shortages, that people became a lot more comfortable using ketamine. And so I think we use that a lot more. And then things like pregabalin, sometimes NSAIDs and lidocaine, but those are certainly less commonly used due to side effects. So that's our pain component. Next, we move on to the B, which is combining both spontaneous breathing trials and spontaneous awakening trials. So what are these things for those of you who are sort of more critical care based? A spontaneous awakening trial is really in patients who are sedated and ventilated, turning off their sedation to try to have them spontaneously wake up and see what happens. So before we do that, we want to make sure it's safe, right? So patients shouldn't be having active seizures when you turn off their sedation. They shouldn't be paralyzed like on paralytics. They shouldn't be already agitated because you're only going to make them more agitated by turning off their sedation. They should not have active myocardial ischemia, which obviously is a problem in your ICU. And ideally have normal intracranial pressure, which is more of a civic ICU problem. If they pass that safety screen, then we would go on and turn off their sedation. And then you would decide, do they pass or fail? What does failing a spontaneous awakening trial mean? Oftentimes it's agitation, right? They get agitated, they start thrashing around in the bed, you got to turn the sedation back on. But tachypnea is another one, so an elevated respiratory rate, desaturation, respiratory distress, and cardiac arrhythmias can certainly happen as well. If your patient fails their spontaneous awakening trial, they are only supposed to go back to restart their sedatives at half the previous dose. This is worked into the protocol and the system really to try to minimize our use of sedatives, realize, can we get away with less sedatives overall, and trying to prevent the accumulation of these drugs that happens over time. If you pass your spontaneous awakening trial, then you move on to your spontaneous breathing trial portion and again do a safety screen. Is it safe to turn off to reduce the ventilatory support in these patients? Again, the patient shouldn't be agitated, they should be saturating reasonably well, not on significantly high amounts of oxygen. The initial study looked at a PEEP of less than 7.5, which I think we're a lot more liberal with now, and we would allow the PEEP to be higher than that to be safe. No myocardial ischemia. Again, no vasopressor use. This is another one that I think we're much more liberal with, allowing spontaneous breathing trials to happen even when patients are on vasopressors. And they need to obviously be making inspiratory efforts. So if the patient's not breathing, you're not going to take away the ventilator and watch them not breathe. So once you do that safety screen, if they pass, they would go on and perform a spontaneous breathing trial. But things we look for in a spontaneous breathing trial, and what happens is you just remove the support of the ventilator. So there are a few ways you could do that. One way is you can actually just take the ventilator off and they breathe through an endotracheal tube, maybe with some blow-by oxygen, or you reduce the amount of support that the ventilator is providing. Things to look for: elevated or low respiratory rate, oxygen saturations, respiratory distress, acute cardiac arrhythmias. And if they pass, then that's a sign that, maybe this patient, from a respiratory and an awakening point of view, is ready for extubation. There may be other reasons they're not extubatable, but at least it gives you a daily assessment of, can I extubate this patient sooner? Because the longer patients stay on the ventilator, the worse their outcomes are. If they fail, then they would go back on full ventilatory support. And what we've seen, that when you combine spontaneous awakening and spontaneous breathing trials, patients reduce their duration of mechanical ventilation by 3.1 days, which is pretty significant when you think about it. Decrease the need for tracheostomy, because obviously the longer patients stay ventilated, the more likely they are to get a tracheostomy, because we say, well, now they've been intubated for 10 days or 12 days, and we want to give them a trach. And then it actually decreases the risk of delirium and coma. And I think a lot of that is related to the reduced sedative use that goes along with those spontaneous awakening and spontaneous breathing trials. The next letter within the bundle is C, which is choice of analgesia and sedation. So again, this is for our intubated patients in the ICU, and we use a lot of sedation. The problem with sedation in the ICU is that what that optimum level of sedation or optimum drug even is dependent on a lot of different factors. So the type of patient that you have, a cardiac patient versus a 20-year-old septic patient, are the drugs and the quantity of drugs you're going to need are going to be very different. Comorbidities of the patient, illness severity. So we saw this in COVID, that patients required incredibly high doses of sedatives and narcotics in order to be able to appropriately ventilate them. And then the treatments and interventions you require. And achieving that optimum sedation in critically ill patients can be really challenging. And that's because patients have really unpredictable pharmacokinetics. They've got multi-system organ dysfunction a lot of the time. They get disease-associated encephalopathy, so septic encephalopathy, and their acuity of illness fluctuates. So what they need one day may not be what they need the next day. And so not only is it hard to pick a drug and a dose for a specific target, but that target also changes over time. And what we've seen is that more and more studies are showing that when we over-sedate patients, we do harm to them. And so that's why we really want to not over-sedate our patients. That being said, there are some times when we need to sedate patients. So our reasons to sedate a patient are to reduce anxiety and stress. Decreasing pain if we're using opioids as our sedative. We want to ensure their comfort. No one wants to. We didn't go into medicine to torture people in a bed. Like, we want to try to make sure that they're comfortable. Reducing oxygen consumption and CO2 production, which I have to say from a general ICU perspective is not something that we do very much. I think maybe in the CICU that's a little bit different for patients who have really bad myocardial ischemia. We sometimes use sedatives to facilitate treatment. So things like mechanical ventilation, for example, the COVID example that I gave you. I say maybe facilitate nursing care. And I think this is an important one in that, often the thought from the nurses are, they obviously want to make patients comfortable, so they want to sedate them. But often if a patient is agitated, using the cobble all the time, it's busy, they've got multiple patients, maybe sedating the patient is actually easier and can facilitate nursing care. My counter argument to that is, if you have a patient who's awake enough that they can participate in their own care, they can help turn, right? You don't need 3 nurses to come and turn the patient, because the patient can actually help participate. Maybe the patient can participate in, mouth care that takes work away from the nurse. And the other thing is maybe to maintain patient safety. Again, sedating patients, sometimes we think the more we sedate them, the less likely they're going to be to pull out lines or tubes. I actually think you increase the risk of them pulling out a line or tube unless you make them completely comatose, because now they don't remember that you continually tell them, don't pull out your tube, because they're on propofol and they have no memory. They're completely amnestic to everything that you've told them. So although often we sedate people in the spirit of maintaining patient safety, I'm not sure that that's always the right thing to do. And then our negative side effects of sedation. So definitely adverse physiologic effects. We see that all the time. Propofol, people's blood pressure drops. Same thing with fentanyl. We can get bradycardic from some of the other drugs that we use. Patients can have prolonged mechanical ventilation. So certainly the deeper you are sedated, the longer you will be on the vent. Difficulty assessing mental status. So this is more of an issue sort of in a neuro ICU where patients are on sedation and then maybe they're not responding. And the question is, oh, is that their neural status that's changed, or is it the drugs? And often we end up sending them for a therapeutic CT scan where they wake up in the CT scanner. Ventilator-associated pneumonia is another one. The longer you keep people on the vent, the more likely they are to get a pneumonia. Delayed mobilization, you can't get people up and moving if they're comatose. Delirium and persistent psychologic dysfunction, and that we'll talk about a little bit later when we talk about some long-term outcomes, but we do know that sedatives actually negatively affect people from a psychologic point of view down the road. So in terms of how we should be sedating people, a lot of what I'll talk about, and you can see the reference down at the bottom, is from what we call the PADIS guidelines. So it stands for pain, agitation, delirium, immobility, and sleep. Really immobility being rehabilitation, but they needed a vowel. And so the PADIS guidelines for sedation say we should be targeting light sedation. So that's a RASS of -2 to +1, meaning like ideally awake, a little sleepy, but they wake up to voice, or maybe they're just slightly fidgety in the bed. That's kind of our optimal level of where we would like people. And doing that leads to less time to extubate people, less tracheostomies, shorter ICU length of stay. The other thing that these guidelines talk about is analgesia for sedation. So remember I said sometimes we use narcotics as a sedative. What the guidelines are really trying to stress is you need to be able to assess and treat people's pain before you go and sedate them. Because if you just go and sedate them, they then can't tell you if they have pain. So they may actually have underlying pain that you're not doing anything about because you've sedated it away. But it's not really gone. They just can't tell you about it. Okay. So we assess people for pain, we treat their pain, and then we would move on to sedate if necessary. And that sort of strategy for sedating patients, called analgesia for sedation, leads to less time to extubation, shorter ICU length of stay. In terms of what sedatives to use, the guidelines, you know, that the practice 15 or 20 years ago in the ICU was everyone was on benzos and narcotics. Even when I started, I've been ICU staff for 11, 12 years. There was even still a lot of benzo use then. And what we know is that benzos are actually harmful to patients overall. And so the guidelines are recommending propofol or dexmedetomidine instead of benzos if possible. And the reason for that, again, less time until you're extubated, less delirium, shorter ICU length of stay. Just a quick word about dexmedetomidine. So some of you may not know much about this drug. It's only been around, certainly in the Ottawa hospital, I think it's been around for 12 or 13 years. So not a long time. It's a centrally acting alpha-2 agonist. So I kind of like to think of it as like the IV clonidine. They actually have IV clonidine in Europe, but we don't. We only have it oral here. And so this drug, dexmedetomidine, has been developed. It's got sedative properties. It's got anxiolytic properties. It's got analgesic properties. So it's opioid sparing, which is really nice when you have someone who has pain. And it causes sympatholysis. Minimal respiratory depression. So just really nice in patients that you want to maintain their ability to breathe. One, I say maybe downside, we'll talk about it after, is it can cause bradycardia, which can sometimes limit your ability to use it, and certainly can cause a little bit of hypotension, but no different than what propofol would cause for the majority of patients. So I feel like, you know, I was always taught, I remember, that propofol should not be used in patients with cardiogenic shock because it is a cardiac depressant, it causes peripheral vasodilation. Propofol is a bad drug in cardiogenic shock. I actually tried to review and look at the evidence for this, and it's all like animal stuff that talks about what happens with propofol. They don't even fully understand, from what I read, as to how it happens. So this is a study, it was pretty recent. It's only an abstract, but it was published in 2022, where they actually looked at what happened when they changed their sedative practice. So this was in an ICU where they, in 2017, decided to change from MDAS as their primary sedation to propofol, and they compared the two groups of MDAS versus propofol in like a before-after study. And you can see here what they found. So this graph here on the top looks at their catecholamine dose, so really their vasopressors. And interestingly, The group in the propofol group needed less catecholamines, less pressors than the midazolam group. And they actually had decreased mortality in the propofol group. So, I mean, it's a super small study. It's before and after, but I just think it's one of those things where I usually, even in a patient on significant pressors in the ICU, because often, although yes, we get, a lot more sepsis than cardiogenic shock, patients often have cardiac dysfunction as well. I will always try propofol first. It's fast on, fast off. If clearly it drops their blood pressure significantly, I stop it. But I think this is just sort of food for thought that maybe all of this stuff that we've learned about no propofol in the setting of cardiogenic shock is not necessarily true. In terms of dexmedetomidine, again, it's a newer drug. I've never seen any specific studies looking at dexmedetomidine in the setting of cardiogenic shock or specifically in cardiac patients. That being said, there is this interesting cohort study that was published. So it was a database study looking at over 22,000 patients and looking at the risk of new onset atrial fibrillation in patients and comparing those who got dexmedetomidine to those who didn't. There's actually a pretty significant decreased risk of atrial fibrillation. And atrial fibrillation, as we know in critical care, is incredibly common, definitely has negative side effects to it. And so just sort of, again, food for thought that, maybe dexmedetomidine might be a nice choice for someone who's really high risk AFib or who is an AFib who you want to try to keep them out of it. Also had decreased in-hospital mortality, which looks pretty significant, but again, this is like observational cohort. It's would need to be studied in further form, but just again, a little bit of food for thought. So that's our sedation piece. Moving on to delirium. So for delirium, we want to, assess, manage, and treat. This is a very interesting, somewhat disturbing headline that came out in 2015. So the headline, as you guys can see, blood seeping from the walls, killer doctors, ICU hallucinations haunt a staggering number of patients. This was published after a U of T philosopher, young woman, developed sepsis and ARDS and was in a Toronto hospital for weeks at a time. She had absolutely horrible delirium. She describes very vividly stories of doctors dancing in her room, making fun of her, trying to kill her, blood on the walls, very, very disturbing memories. And so they wrote an article about this. And the thing is that these are not isolated cases. This is the majority of our patients. If you can get to them and ask them afterwards, they will tell you they have these stories. So there was a young lady who was actually here on ECMO for several days after a drowning, and then ultimately came to the ICU. And I met her a couple of months later and said, like, what do you remember? And she has this very vivid memory of being taken to a stairwell and the nurse is pushing her down the stairs and watching her at the bottom of the stairs and laughing at her. She's like, I know it didn't happen, but it was so real in my mind. And so these memories are really disturbing to patients, and are incredibly common. So we know that delirium in the ICU happens in anywhere from 50 to 80% of patients, definitely much more common if you're intubated than if you're not. And it's often undiagnosed. So oftentimes these people are having these thoughts and hallucinations and they're not telling you. You have no idea it's going on unless you're actually going in and assessing it with validated tools. Very disturbing to patients, but also to families. And I would say this is probably the most disturbing things, one of the most disturbing things that our families see. We see that they're on 3 pressors, that their lactate is 10, that their creatinine is 400, that they're in DIC. We all worry about that. But what the family sees at the bedside is their loved one hitting the nurses, telling them they think someone's trying to kill them, saying these horrible things to them, and really not being themselves. And that's really disturbing to families. In terms of risk factors for delirium, so there's these pre-existing things we can't do anything about. History of dementia, hypertension, probably because of chronic microvascular changes, alcoholism, higher severity of illness is definitely a risk factor, and then age. So the issue of age is an interesting one, and there's some studies that'll show that age is a risk factor for delirium in the ICU, and some say that it's not. And I think the thing to remember and to note is that high severity of illness can overcome young age and a nice healthy brain. We will have 20-year-olds who have pretty horrible delirium, like the story of this girl was 18 who was on ECMO. So delirium does not spare the young. And then there are acquired risk factors, things that we do to patients that will increase their risk of delirium, and that's coma. So the deeper we sedate people, the worse it is, and benzodiazepines. I say maybe opiates because that's another one where some studies say, yes, opiates are bad, they cause delirium. Other studies where they say, well, we're not sure. There's actually one study in the burn population in an ICU that shows that opioids were protective against delirium. I think that's probably because uncontrolled pain in and of itself can be a risk factor for delirium. So we definitely want to treat pain. We want to make sure that we're treating it, but we don't want to use too much drug because of the negative side effects of it. Why do we care about delirium so much? So yes, it's horrible to hear these stories of what patients are experiencing, but there's also a lot of really bad outcomes associated with it. So patients will spend more days on the ventilator, more time in both the ICU and the hospital afterwards. More patients will become institutionalized afterwards. So that's like nursing home, retirement home, chronic care facility. Patients develop long-term cognitive impairment. And there's actually interesting MRI studies that have been done that look at like people who've had MRIs pre and post delirium, and you actually see brain atrophy. Something happens within the brain that's really not fully understood, but these people's brains are changed forever. And increased mortality. And the duration matters. So the longer you are delirious, the more likely you are to have cognitive impairment and the more likely you are to die. There was one study that showed that for each day of delirium, you increase your risk of death by 10%. Now, that doesn't mean by 10 days of delirium, everyone is dead. But it shows that the longer it happens, the worse it is, which is why it's so important to try to shorten that duration of delirium as much as we can. The problem is we don't really have great drug treatments in order, or nothing that has really been well proven to shorten our duration of delirium. So those PADIS guidelines, like I talked about, discourage actually routine use of antipsychotics. And that's because there isn't great evidence for them. There is more stuff coming. There was another recent New England study that looked at Haldol versus placebo that actually showed no benefit, although there's kind of a trend to benefit there. And so, you know, the problem is that delirium and ICU patients are so diverse that there probably is a subset of population that it works for. We just haven't figured that out yet. Some patients that may benefit from antipsychotics are those ones who have like severe anxiety, who are fearful, or having hallucinations and delusions. Maybe from a symptom point of view, we should try to use antipsychotics, or those ones who are so agitated that they are harmful, that they are a harm to themselves and others. But the important thing to remember is that if antipsychotics or other adjuncts like clonidine that often get started in the ICU for treatment for delirium and anxiety, that these medications are often continued after discharge from hospital. So there was actually a big database study done in the US that showed, I think it looked at like over 20,000 patients. Patients were admitted to hospital on no antipsychotic, and 21% of those patients were discharged home on antipsychotics after an ICU stay. 21% of patients did not develop an acute psychotic disorder. They were delirious, they got started on a drug, and a lot of it just got forgotten and left there. So just a thing from a ward point of view, ward cardiology point of view, when you get these patients out afterwards, just take a look at their drug list. It's one of the things that when we do race follow-ups, I always look at the drug list and say, oh, look, they're still on the Seroquel that we started them on. FYI team, this should be weaned off. The best evidence that we have for delirium management is really, again, these multi-component interventions. So things that reduce and shorten duration of delirium, like reorientation, cognitive stimulation, you know, sitting there talking to them, have family, bringing in pictures, things that will remind them of stuff, use of clocks, improving sleep. So trying to minimize light and noise. Sleep in the ICU is an entire other topic, but it is very difficult to sleep in the ICU or in the hospital at all, but anything we can do to try to improve that. Reduce immobility. So try to rehabilitate and move our patients, which is the next thing that we're going to talk about. And then reduce hearing and visual impairment. So give people their glasses and their hearing aids if possible. These all seem like such simple little things, like, oh, that's not going to make a difference. But when you put it all together, I actually think it can make a big difference. So now we're going to move on to our mobilization component. So that's our E, being early mobility and exercise. So this is a patient that we had in the general ICU several years ago after we started our, what we called it was a PEDS protocol, standing for pain, early mobilization, delirium, sedation, and sleep. So really same thing as PADIS, but we just chose different letters. We did it before them. I like ours better. So this is a lady, she was actually admitted with a submental hematoma that caused airway compromise. And so she needed to be intubated for that. Very motivated and wanted to be up and moving. She had an underlying cancer and she was like, the longer I stay in bed, the worse this is going to be. Get me up and move, and use my picture to teach everyone else about it because movement is important. So you can see here that she has a, let me use the pointer for a quick second. So she's got her portable ventilator right here. She has her monitor here. Here's her endotracheal tube. Interestingly, she's actually running a propofol infusion that is running right here, but at a very low dose, enough that she can be comfortable out walking. She can participate. You know, this is the ultimate goal for patients. Obviously, it is not what every patient is going to get. Early mobilization in the ICU is something that started about 15 years ago. It's interesting when you speak to like retired intensivists, they're like, this is what we did 40 years ago. It was like, wake them up and move them. We went away from that by deeply sedating patients for a really long time to allow them to rest and heal. And now we realize that we've harmed patients by doing that. And so the pendulum has swung back to trying to get patients up and moving again. So early mobilization is physio mobility activities that start immediately once the patient is physiologically stable. They may still be on pressors, they may still be intubated, but you can start to do stuff with them. That can be anything from gradual progression from dangling at the side of the bed, so literally just sitting at the side of the bed, which you would think is not a lot of work, but it actually requires a fair amount of trunk control. You know, our babies can't do it when they're first born because they've got no trunk control and head control. That's what happens to ICU patients after a long time in the ICU. So dangling at the side of the bed, sitting, standing, sitting in a chair, marching on the spot and walking. So here's another gentleman that we have. I have another picture of him and he's reading, it's called Mornings with Maury, or anyways, one of those books. It's like a very famous book. He was sitting in the ICU with his endotracheal tube reading, but he's there standing. So again, this can happen and it doesn't have to be every patient up and walking. Where did this come from? So this started with this big landmark trial in 2009. So by someone named Schweiker. He took 104 sedated patients who were sedated with daily interruption of sedation. So the sedation spontaneous awakening trials like we talked about. And he randomized half of them to early mobility, early exercise and mobilization with a physio and an occupational therapist. And then the other half got just whatever the team ordered, whatever standard of care was. Their primary endpoint was independent functional status at hospital discharge. So are they able to walk independently and can they perform their 6 activities of daily living? Secondary endpoints looked at number of days in the hospital, looked at delirium, looked at ventilator-free days. And what they would do initially was perform a safety screen. So again, not every patient is this going to be safe to do, but you need to assess which patients you can do it in. So does the patient respond to verbal stimulation? If you've got a completely comatose patient, you're not going to try to get them up and walk because obviously they're not going to be able to cooperate. So they had to be at least a RASS of -3. I would argue RASS of -2 is much safer than that, but they used RASS of -3. They had to have an FiO2 of less than 0.6, a PEEP of less than 10. They couldn't have had any increase in their vasopressor doses in the last 2 hours. So again, they could be on pressors, but they just had to be on a stable dose of vasopressor. They shouldn't have evidence of active myocardial ischemia. Again, that's going to be your limiting factor in the CCU. And they shouldn't have any arrhythmias requiring new administration of antiarrhythmic drugs. So if they passed that mobility screen, then they were cleared to go ahead. If not, then they could get range of motion and stuff in bed, but nothing more than that. And the outcomes were impressive. So what they found was that 59% of patients in the intervention group were functionally independent at hospital discharge versus only 35% in the control group. Regardless, it's a lot of patients who are not functionally independent at the end of an ICU stay, which again, we'll talk to later, and it speaks to the how bad people can be after the ICU. But this is something we can do that can make a really big difference for patients. When they actually looked at when that mobilization started, in the intervention group, it was within 48 hours. And in the control group, it was 7 days before they got up and moved. Rehab often uses the, rehabilitation physiatry doctors often use the I don't know, calculation of for every 1 day in bed, that's 4 days of rehabilitation. So you think of that alone, getting them up after 2 days versus after 7, that's a huge change to their ability to rehabilitate afterwards. Some other secondary outcomes that they looked at was duration of delirium. And you can see it went from 4 days in the control group to 2 days in the intervention arm. There's no drug that we use for delirium that will reduce your duration of delirium by 2 whole days. Mechanical ventilation was reduced, maybe a trend towards shorter ICU length of stay, and then nothing significant for hospital length of stay. And the important thing was that adverse events were actually quite rare, right? What people worry about here is how can you mobilize an ICU patient? Like, they're so sick that's got to cause adverse events. They had only 0.2% of sessions. 4% were stopped prematurely due to patient instability, and usually that was patient ventilator dysynchrony. And they said, oh, okay, let's stop. The patient's not comfortable on the vent. So many benefits to early mobilization. There have been other studies that have come about afterwards. So patients have improved muscle strength, better physical function and quality of life, more likelihood of functional independence, as we talked about, less ICU acquired weakness. ICU acquired weakness is sort of this grab bag term for neuropathy and myopathy combination that can happen in ICU patients. Less days of mechanical ventilation, reduced depth of sedation, which I find an interesting one. And I think a lot of the reduced depth of sedation that you see in patients are mobilized is because you've given the nurse a reason to turn down the sedation. If you say, we're going to come and do a mobility activity at 12:30, can you try to get them light enough so that we can actually have them participate? They do that, and then they realize afterwards, hey, patient's actually pretty cooperative and comfortable on this level of sedation. Let's just leave it lighter. And then the other thing is that I think working with a patient, having multiple people, trying to get them up and walking actually stimulates them to be more awake and therefore less sedated. And then this decreased incidence and duration by 50%, which I think is huge. Now, as I said, this has only been a thing in the ICU for about 12 to 15 years, and that's in the general ICU. Well, what about in CICU? And there's very little evidence in the CICU for doing this. It doesn't mean it shouldn't be done. It just means it hasn't really been studied that well. But there is this study. It was a retrospective study. It's actually Canadian. It was done in McGill. And so they did a before and after study where they implemented an early mobility program and looked at their outcomes before and after implementation. And their primary outcome was discharged home. And they had a significant difference, 83.9 versus 78. So like not huge, but 5% difference in their ability to discharge patients home. And then secondary outcomes they looked at was in hospital death. And more importantly, adverse events. Again, it's, 1,400 patients is a fair number of patients. More would be better in terms of a safety for numbers for safety. But the biggest events that they saw were transient desaturations and arrhythmias, and none of the patients had like a negative outcome because of those adverse events. So just goes to show that, I think we can be mobilizing some of these patients. Just to give you an idea of what kind of patients these were. Big reason I put this up here. So age about 68, just to see how it relates to your own CICU. About 60% males, 35% about of patients were admitted for ischemic heart disease, heart failure, and about 10 to 15% AFib, so other grab bag. These weren't cardiogenic shock patients, but again, they may not pass the safety screen. I think an interesting study to show that it certainly can be done in cardiac ICU. In terms of safety overall, the PADIS guidelines actually went through and compiled all of the information from every trial that there's been on safety in the ICU and found that when they combined them all, there was over 12,000 sessions across 13 studies, 12,000 sessions of mobilization, and there were only 15 serious safety events. So it's like 0.01%, like super low. If you know what you're doing, if you pick your right patient, this can be done safely. And in terms of picking the right patient, there were some really nice consensus guidelines that were published actually before those guidelines. But I really like them because they take out like a color-coded red light, green light, yellow light approach. So it was a systematic review that they did, and then a meeting of 23 people who were like the know-alls in early mobilization. Carol Hodgson was the primary author. She's a big guru in mobility. The other person was Dale Needham. He's another one in Johns Hopkins who's a big guru in mobility. And they summarize things into 4 categories, looking at respiratory stuff, cardiovascular, neuro, and other. I'm only going to highlight the cardiovascular stuff for you guys because it's the Heart Institute. So as you can see, red light, yellow light, green light. The first column, what is this? So this column here is, can you do in-bed exercises or out-of-bed exercises? So, for a patient who's on IV antihypertensive therapy for a hypertensive emergency, you're not going to get that patient up and out of bed, okay? But for patients, so I think these two are important. If they are, either at or above their target MAP score with either light levels, or I think they call it low level of support, or moderate level of support, that's a green or a yellow. Like, you can get those patients on pressors up. It is safe to do so. Other things that are applicable to you guys. So, if someone has bradycardia and they require pharmacologic intervention, we're not getting those patients up and walking. But if they are not requiring pharmacologic intervention, they're not awaiting an emergency pacemaker, like maybe you can actually get those patients up. And then same thing with pacer wires. So if they're pacer dependent, in bed activity, you can do, with caution. You're not going to get that patient up, because if their pacer wire gets dislodged, you're in big trouble. But if they've got a stable underlying rhythm, then yes, go ahead and mobilize them. And then some of the other ones are looking at balloon pumps. So in-bed exercises, they say, is a full green light for balloon pump, that you can do in-bed exercises, but not out of bed. And then ECMO stuff, so in bed, has a green light, and even a yellow. For this one, they say for a bicable dual lumen catheter. Toronto actually does a lot of ECMO in their, a lot of mobilization in their ECMO patients, because many of these patients are awaiting lung transplant, and they are actually trying to get them fitter in the ICU in order to tolerate their transplant. So they use their ECMO to try to do that. They have a wheeled treadmill that they wheel into the ICU rooms, and they tee up to the side of the bed so that the patient sits up, and then their feet are dangling over top of the treadmill, and all they got to do is get up and start walking on the treadmill connected to their ECMO. It's pretty impressive to see some of the videos. So that's our mobilization piece. I think safe to do in a cardiac ICU if you pick the right patients. Then we move on to our family engagement and empowerment. And this is really, to me, this came to light more when in COVID, we prevented families from coming into the ICU, okay? We did not have flexible visitation, which is important for patients and families. Families were not allowed to participate on rounds. We often didn't have time to call them every day with an update. So families are sitting at home not knowing anything that's going on. We are therefore not able to understand from families what a patient's preferences are, right? Do they like music? Do they like TV? Is there something that we can put on for them that might make them happy? How do they usually sleep? Oftentimes we hear from families they never go to bed until 2 a.m. and they sleep until 11. You're like, okay, well, why am I trying to drug them to sleep at 10 p.m. because it fits with our schedule? That's just not how they are. And then the other important thing is that we can involve family in mobilization. And actually, in that cardiac study that I showed you, families were actually involved in the mobilization as an extra set of hands. And so I think it's really important, both for patients, but also for families, because families themselves become very, very affected by their loved one's ICU stay. And I think we are starting to recognize, especially after COVID, we've probably given a lot of family members PTSD from them not being allowed to be in the ICU through that time. And that brings us on to post-intensive care syndrome, okay? And I think, as we've talked about, there are all these negative effects that can happen after you stay in the ICU, and your recovery, we were talking about patients are surviving, but they're not recovering. That recovery is hindered by, you can think about it, what post-intensive care thinks about it as is 3 domains: your cognitive domain, your psychological domain, and your domain of physical impairments. And you can have any one or all of those to be considered to have PICS. PICS has a lot of impact on patients' health, their quality of life, and healthcare costs. They end up going in and acquiring healthcare services much more commonly than patients who don't have PICS. When we think about the cognitive impairments that can happen to these patients, they get impaired executive function, memory, attention, processing speed. A lot of these people just say, I feel foggy, I can't work, I can't concentrate. I had a patient from my medical school class who, or a friend from my medical school class who got admitted with, I think it was a peripartum cardiomyopathy, it wasn't entirely clear, but was in the ICU for a period of time. And she tried to go back to work after 6 months. And she was like, I can see half the number of patients that I used to be able to see. I'm just not as fast as I was. I'm not the same cognitively. It's seen in up to 100% of ICU survivors at hospital discharge, and even years later, like 50, 60%. The big landmark trial in outcomes that was done, the first one by Margaret Herridge, followed H1N1, was it H1? Yeah, H1N1 patients. And found, no, I lied, it was SARS patients. It was even earlier than that. They followed SARS patients, and the average age was like 46. And after 1 year, only 35% of those patients were actually back to work. And it wasn't because of respiratory issues, it was mainly because of the cognitive issues that they have afterwards. And so when I feel like this is also important from a cardiologist point of view, is that when you see these patients in your clinic afterwards, whether they come from the CICU or you're seeing them and they've been in our general ICU, these patients may have these deficits and complain of these things down the road. Some of the risk factors that we know for cognitive impairments is patients being delirious in the ICU and our sedative use, which then ties back into why we're trying to decrease those. When we think about psychologic impairments that these patients have, so often patients develop acute stress disorder, anxiety, depression, PTSD, and sedatives can actually be a risk factor for this. Patients develop what we call sedative-induced delusional memories. So some of them are like the hallucinations that they have that they remember. Some things are that they actually misremember things that happened to them. So they may remember a common one and very disturbing one is after having a Foley put in, they'll remember that as being sexually assaulted in the ICU, and they're convinced that that happened. And you can see where they're coming from. They had a Foley put in, but the intent was never assault, of course. And what we actually know is that higher dose benzos are associated with more PTSD after discharge. So again, I think that's probably because the deeper you sedate someone, the less likely they are to be able to fully understand what's going on and to be able to form appropriate memories. And then our last domain is the physical impairment, which, as I talked about, this ICU acquired weakness, which is a term that encompasses both critical illness polyneuropathy and critical illness myopathy. There've been some talk recently. This paper was published in 2021 that looked at expanding the PICS definitions, because we're seeing all these other things that kind of don't fit into those three categories. So things like chronic pain that we had talked about, sleep disorders, significant fatigue. And a lot of this stuff is affected by their baseline status, things that we did to them in the ICU, and then the care that they get after the ICU. Some of the other important things to talk about are the endocrinopathies. So people often get thyroid, adrenal, and hypothalamic abnormalities from an endocrine point of view. Sexual dysfunction is a big one that young people will complain about after an ICU stay. Changes in appearance can be really disturbing to people. They develop alopecia, and that young 18-year-old, I remember she said to me, like, why am I losing all my hair? I'm going bald. I'm like, we did that to you. Like, that is your ICU time that did that. And they end up very, very scarred, like physically scarred, right? They often have a trach scar. They've got multiple scars here. And for some patients, it doesn't bother them. They're like, you know what? I'm happy I'm alive. And other patients are really bothered by it because every time they see a person, they're like, what's that from? And it brings them back to the ICU and all of those memories that they have. Patients have taste changes. Why this happens, we don't know, but then they don't want to eat. And so then their nutrition is impaired, and then it's even harder for them to recover. And then procedure-related complications, so rectal and urethral injuries. We see a lot of patients with stool incontinence after an ICU stay, and it's probably because of the rectal tubes that are used pretty commonly. Vocal cord dysfunction is another one. Their voice is never really the same, and then patients can go on to develop tracheal stenosis, either from a prolonged intubation or from a tracheostomy. So all of this sounds horrible, but we want to try to prevent all of this stuff from happening. And don't get me wrong, a lot of patients are still really happy to be alive, but I think that we can do better to try to prevent this stuff from happening. And that's by, limiting sedation as much as we can, by optimizing ICU nutrition, which is a topic I thought I would talk about, but I felt like it was really not that interesting, although important. Hopefully there's no dietitians in the room. Promoting exercise, and then engaging families in recovery. One of the things that's often talked about is ICU diaries, and in engaging families in doing this, where a family member will write every day, like, today you went down and had a perm cath put in, today you went to the OR, this is what happened on this day. And a lot of patients say, you know what, it was actually really helpful because I kind of remember something about that. And when you've written it down and describe it to me, now I understand. Patients can be really disturbed that they won't remember 2 weeks of their life, where clearly the family remembers every detail and was traumatized through the whole thing, and they remember nothing. And so writing these ICU diaries can be really helpful. I thought this was a really nice diagram sort of describing PICS and sort of bringing this all back together in terms of how the ABCDEF or A to F bundle can affect things. So as I mentioned before, we know that patients' pre-existing functioning will definitely affect their post-ICU recovery, which makes sense, right? So on this graph, we see, again. So on this side here, this is someone's functional independence and quality of life. Okay, so you've got patient A who is clearly very highly functional. You know, maybe they're young, they don't have coexisting illness, not frail. Then you have patient B who's like a little frail, maybe a bit older. And then you have patient C who, you know, is quite significantly frail. Maybe they have cognitive issues at baseline. This is all in their pre-ICU time. In this section here, is when they're in the ICU. So you can see all of these patients plummet, right? Their physical function and quality of life plummet significantly while they're in the ICU. Patient C, because they start off at such a low point, dies. No matter what we do in the ICU, we're not going to be able to make that person survive. They pass away. Patient A plummets, but recovers. But you can see they don't recover to their pre-function. And that's because of all of the stuff we've talked about, all of the sort of PICS elements. And this is while they're in the hospital, and this is when they're out either in a rehabilitation setting or out in the community afterwards. Patient B is the same, plummets while they're in the ICU, comes up, but then you can see as a sort of visual, if we were to implement the ABCDEF bundle at this point, you know, maybe they don't plummet quite as low, and therefore maybe their post-function does not become quite as bad as it was going to if we hadn't implemented all of those things. So we can't prevent this stuff from happening fully, but maybe we can mitigate some of those effects by implementing the components of the A to F bundle. The other thing that this diagram brings up is the need for longitudinal follow-up of these patients. Okay, so having a sort of interprofessional group, multidisciplinary rehabilitation, mental health are the two big things that they need. Drug reconciliation, making sure that, like, you know, those antipsychotics are not on when you see them at 3-month follow-up. And really advocating for these patients up to a year out. I think a lot of the time, you know, patients go back to their family doctors, and family doctors don't understand this, and they're like, well, why can't you go back to work? Like, you are better now, you're home, you should be good enough. And they're not. So I think we need to do a lot better in terms of advocating for patients afterwards, but also following them and trying to improve things. There have been studies that have looked at ICU follow-up clinics. And unfortunately, the results have been mixed. But the reason I think they have been mixed is because of this premorbid functioning, right? In that if you've got a patient like C who somehow didn't survive, you know, maybe a patient B.C, like someone in the middle there, you know, it's going to be really hard to do any rehabilitation to get them back to a good quality of life when they started off at a lower spot to begin with. And so I think a lot of those ICU follow-up clinics that we've seen, that is what prevents us from seeing a big benefit. I still think even if we can't improve, you know, hard outcome numbers, patients and their families find it very therapeutic to come in and visit and say, they often like to come into the ICU and see the place and see the nurses to remember sort of what happened. They find it therapeutic for them. And I think it can be therapeutic for patients as well. It's certainly an ICU follow-up clinic. Dr. Megason does a little bit of it here, mainly through trials. And then I understand, I think the CICU group here has started a follow-up clinic, which I think is absolutely wonderful. And would love to tap into more of that for our ICU patients. So in summary, critical illness has a lot of long-term consequences that significantly affect physical function and quality of life. But that A to F bundle is actually our way to try to change that. I don't mean this to be like a Debbie Downer talk because it seems all sad, but I think this really is an opportunity to tangible things that we can do in the ICU to try to improve outcomes. And I think we can do a lot more work on prevention and long-term follow-up of PICS, and that's something that certainly we in the ICU would love to collaborate on. Okay, if anyone has any questions, please take them.
Thank you so much, Erin. That was excellent. I'm just going to close this actually so we can get into. Sorry. I know. Yeah, exactly. Just want to see. There we go. So if anyone has any questions, you can please raise your hand. Otherwise, I'll just ask one question. Regarding the follow-up, it's obviously resource intensive to arrange the follow-up clinics. But as you say, I think horribly important, because even when they come to the ward, unless you've been seeing them in the ICU, you don't get a sense of everything that happened in that 2-week, 3-week, 2 month stay, unless you're there on a daily basis. Is there a population that you think would benefit the most, given it's so resource intensive? Is, in your opinion, is there a population that would, could you target a group that would be more benefit from the follow-up?
Yeah, for sure. So, I mean, I have a couple of thoughts on the populations to target. One, I think, is the patients who are going to be more likely to get it. So that's the longer duration of mechanical ventilation, ideally over 7 days, which I know in the CICU, often patients are not ventilated that long, but certainly if you're going to try to target a small population, the longer time of ventilation. And then the other thing, if you're trying to, look at resource allocation, as I mentioned, these follow-up clinics have shown no benefit sometimes for patients who had poor functional status at baseline. So maybe actually targeting those patients who had the best baseline functional status to make the most difference to those patients who actually have the most potential to recover afterwards would sort of be my answer to that. I mean, the big thing about these follow-up clinics is aligning yourself with the subspecialist that you need. Truthfully, from like an ICU point of view, we don't really do much for them other than recognize these problems that happen and then make referrals, right, for psychiatry services or psychology service. So aligning yourself with those subspecialties to say, like, I need a physiatrist who's going to help from a rehab point of view. I need a psychologist who's going to be my go-to person. I need a psychiatrist who's going to be my go-to person, and sort of aligning a clinic in that way. I think that would be just my advice.
Are there any other questions from the audience or in the chat box? Look to see. Okay, if not, thank you so much. That was so helpful. A lot of pearls, I think, for us that see these critical care patients daily or frequently. And we look forward actually to working with the ICU and improving our knowledge in the critical care realm. We have so many patients in this building that fall under that umbrella. Yeah, so thank you so much. We really appreciate it. Have a good day, everyone. Please join us next week for rounds. Announcements will come out later this week regarding next week's topic. Have a good week.